Welcome everyone. So today we are going to learn about the management of diabetic ketoacidosis as per the ISPAD guidelines. What does ISPAD stand for? The ISPAD stands for International Society for Pediatric and Adolescent Diabetes. Diabetic ketoacidosis is a condition which is a potentially fatal condition because children can die in diabetic ketoacidosis due to cerebral edema, hypokalemia, aspiration pneumonia, and inadequate resuscitation, and various other causes also. That's why it is prudent to manage diabetic ketoacidosis properly, for which different societies have given different guidelines. One guideline we have discussed in detail before is BSPED guideline, and today we are going to learn about the ISPAD guideline. And at the beginning I'll post another video in which I compare and point out the major differences between the ISPAD and BSPED guideline in the management of DKA. So first, coming to the diagnosis of DKA. Basically, diagnosis of DKA refers to the diagnosis of D, K and A. That means diabetes, ketosis and acidosis. So to diagnose diabetes, we need a random blood glucose level higher than 200 milligram per deciliter. We need, for to diagnose ketosis, we need either presence of ketonemia, that is high blood ketone bodies, or ketonuria, that is high urine ketone bodies. Blood in blood we mainly measure beta hydroxybutyrate, that has to be more than or equal to 3 millimole per liter. But suppose if blood ketone body measurement is not available, we can take the help of point of care rapid diagnostic testing kits to diagnose ketonuria, in which more than or equal to a value of 2 plus is suggestive of ketonuria. Thirdly, acidosis. Acidosis refers to a venous blood pH of less than 7.3 or a plasma bicarbonate level of less than 18 millimole per liter, which we can know by drawing a venous blood gas. So what are our goals of therapy in the management of diabetic ketoacidosis? We know that the diabetic ketoacidosis patients have a lot of fluid deficit in the forms of dehydration. That's why our main goal of therapy is correcting the dehydration. We have to correct the acidosis also, because acidosis in itself can cause a lot of complications and comorbidities. We have to reverse the ketosis. We have to gradually restore the hyperosmolarity and blood glucose levels to near normal. We have to monitor for acute complications that can develop as a result of the diabetic ketoacidosis itself, or as a result of the treatment that we are instituting. And we have to identify and treat any precipitating event as a form of permanent cure. So some general rules of management. The emergency management of ABC, that is airway, breathing and circulation, should follow the PALS guidelines, that is Pediatric Advanced Life Support Guidelines. The management should be conducted in a center experienced with treatment of DKA in the children. Suppose you work at a setup which has no or little experience about managing diabetic ketoacidosis, how to prepare the insulin, how to administer the insulin, how to prepare specific IV fluids, etc. It is better if you start the treatment and refer to a facility which has better experience in the management of diabetic ketoacidosis. Meticulous monitoring of clinical and biochemical response to treatment and timely adjustment is necessary. The fluid replacement should begin before starting insulin therapy by at least 1 hour. When we are starting the treatment of diabetic ketoacidosis, it is prudent that we start the fluid first and give a gap of 1 hour, after which we start the insulin therapy. We have to keep in mind the potassium level, because insulin has a known side effect of shifting the potassium from the extracellular to the intracellular compartment, which can precipitate hypokalemia if not already present. We'll discuss this in later. And bicarbonate administration is not recommended. Many beginners think that the initial presentation the pH is very low, like 7 or 6.9 or something like that. So there is an inherent tendency to administer bicarbonate correction, but it should be emphasized that bicarbonate administration is not recommended and rather contraindicated in the management of diabetic ketoacidosis, because it is associated with increased morbidity and mortality. What are the specific indications of bicarbonate administration in DKA? We will discuss that later. Insulin should not be given through a central venous catheter unless it is the only available option, as infusion may be interrupted when other fluids are given through the same line and there is a large dead space leading to erratic delivery. we have to always think that we have to avoid placing a central venous catheter as much as possible in diabetic ketoacidosis, because there is a high risk of thrombosis, and placing a central venous catheter can increase the predisposition to develop thrombosis. If at all due to some indication we have placed a central venous catheter, insulin should always be preferably given through a peripheral line rather than a central line, because the insulin rate is very less, and if given through a central venous catheter, due to the large dead space, due to the long length of the central venous catheter, the absorption can be erratic, and if we use the same central venous catheter but for both fluid and insulin administration, there may be interruption in administration of either, so that can hamper our treatment. Bladder catheterization to be done only in unconscious and severely ill patients, and antibiotics are indicated in children with evidence of infection. Increased risk of cerebral injury is there if the patient is less than 5 years of age, if the initial pH is less than 7.1, if the initial PCO2 is less than 21 millimeter of mercury, and the initial blood urea nitrogen level is more than 20 milligram per deciliter. We'll discuss this in detail later. So what are the common precipitating events? Omission of insulin injection in a non-diabetic, interruption in insulin delivery in patients using insulin pump, inadequate management of an infection, sepsis, trauma or febrile illness, and many other conditions which ultimately result in one of these three things, that is absolute insulin deficiency, relative insulin deficiency, and increase in amount of counter regulatory hormones or increase in secretion of counter regulatory hormones leads to the presentation of diabetic ketoacidosis. Now we will discuss what is the mechanism of development or pathophysiology of development of diabetic ketoacidosis. So just as we discussed in the previous slide, that whatever may be the cause, there is either absolute or relative insulin deficiency, which in turn lead to increase in secretion of counter regulatory hormones. Those are growth hormones, cortisol, etc. So increase in counter-regulatory hormones and absolute or relative insulin deficiency leads to four complications. What are the four complications? First is increase in lipolysis, second is decreased glucose utilization, third is increased proteolysis and decreased protein synthesis, fourth is increased glycogenolysis. Now we will discuss how these four pathophysiologic events lead to the development of diabetic ketoacidosis. First, coming to increased lipolysis. Increased lipolysis or increased breakdown of lipids leads to formation of increased free fatty acids, which gets delivered to the liver. Increased free fatty acid delivery to the liver leads to increased ketogenesis, which decreases the alkali reserve, and as the alkali reserve is getting depleted from the body, obviously there will be a buildup of acidosis in the body. So increased lipolysis ultimately leads to acidosis. Second, increased proteolysis and decreased protein synthesis. Increased breakdown of protein leads to increase in the gluconeogenic substrates or those amino acids which can take part in gluconeogenesis, so that the gluconeogenesis rate increases. As the gluconeogenesis rate increases, gluconeogenesis means glucose is getting formed from newer substrates. So what it ultimately leads to? It ultimately leads to increased production of glucose, that is hyperglycemia. As the hyperglycemia will develop, it will lead to glycosuria when it crosses the renal threshold, and glycosuria will lead to loss of water and electrolytes. As the loss of water and electrolytes develops, there will be dehydration in the body, and the dehydration by pre-renal mechanism will lead to impaired renal function. When impaired renal function will be there, glucose will start building up in the body, because the kidney will now not be able to excrete the glucose load, so there will be further aggravation of hyperglycemia. Similarly, the dehydration will lead to tissue ischemia and tissue hypoxia, leading to anaerobic metabolism, leading to increased production of lactate, that will lead to lactic acidosis, that will further aggravate the acidosis. Additionally, the decreased glucose utilization and the increased glycogenolysis also lead to hyperglycemia, as is clearly evident from their names. So by these multiple mechanisms, hyperglycemia is aggravating, and all this hyperglycemia will lead to pro-inflammatory changes, which will ultimately lead to insulin resistance at the tissue level. So this is the pathophysiology of development of diabetic ketoacidosis. So what are the major clinical manifestations? The major clinical manifestations are dehydration, that is signs of dehydration, tachypnea, that means increase in respiratory rate, Kussmaul respiration, that is increase in rate and depth of respiration, nausea, vomiting and abdominal pain, and confusion or drowsiness or decrease in level of sensorium. Can you see this child's respiratory rate? See the respiratory pattern. The respiratory rate is obviously increased and also the respiratory depth is also increased. Can you notice? The depth is very high. The child is having deep respiration, rapid and deep respiration. This is called Kussmaul breathing or acidotic breathing, which is a manifestation, which is one of the manifestations of diabetic ketoacidosis. Basically, acidosis due to metabolic acidosis due to any reason can lead to development of this Kussmaul type of breathing. Clinical symptoms relevance. Not all children can have classic symptoms of diabetes like polyuria, polydipsia at the time of diagnosis of DKA, and signs and symptoms of DKA are non-specific. The signs and symptoms we just discussed like dehydration, pain abdomen, nausea, vomiting, Kussmaul breathing, those are non-specific. Those can develop in other conditions also, lot of other conditions also. That's why it is very important to do a finger stick blood glucose measurement in all children presenting with rapid breathing or vomiting and abdominal pain without diarrhea, because we have to keep a high index of suspicion in our mind if we want to diagnose DKA, and we have to not miss the diabetic ketoacidosis. So why the normal blood pressure is present in DKA? Many of you will assume that diabetic ketoacidosis patients have a lot of dehydration, they have a lot of fluid deficit, so maybe they will present with shock or hypotension, that is low BP, but it is not true. Lot of diabetic ketoacidosis patients have normal or even high BP. Why that happens in spite of the fluid dehydration? Because there is elevated catecholamine concentration. It is one of the counter regulatory hormones. So elevated catecholamine concentrations like adrenaline or noradrenaline can lead to increased BP, as you all know. Secondarily, when there is hyperosmolarity, you know that diabetic ketoacidosis and hyperosmolar hyperglycemic state, HHS, all those have a hyperosmolar state. So this hyperosmolar state leads to increase in secretion of antidiuretic hormone by stimulating the V2 receptor. So antidiuretic hormone is getting secreted in increased amount. Antidiuretic hormone means it will cause antidiuresis. That means it will reduce the urine output. That means water and sodium will get retained in the body, which will make the normal blood pressure in the diabetic ketoacidosis, and which will prevent the development of hypotension or shock in diabetic ketoacidosis patients. Thirdly, there is increased osmotic pressure from marked hyperglycemia. That's why fluid is retained in the intravascular compartment, leading to not developing of hypertension in the body. In fact, hypertension is present in 12% of the patients at presentation and develops in additional 16%, that means 28% during the treatment of diabetic ketoacidosis. So hypotension or low BP is not as common as one might think in diabetic ketoacidosis patients. So how to classify diabetic ketoacidosis on the basis of severity? Basically same as BSPD, we have to classify into three groups: mild diabetic ketoacidosis, moderate diabetic ketoacidosis, and severe diabetic ketoacidosis. What is the blood cutoff? We have known that in the diagnostic criteria, a pH of less than 7.3 and a bicarbonate of less than 18 is needed for a diagnosis of acidosis. So the mild DKA will be 7.2 to 7.3 or 7.29. Moderate DKA will be 7.1 to 7.2 or 7.19, and severe DKA will be less than 7.1. Similarly, based upon the bicarbonate levels, in mild DKA it will have a bicarbonate level 10 to 18, moderate DKA the bicarbonate level will be 5 to 10, and severe DKA the bicarbonate level will be less than 5. So this is how we classify diabetic ketoacidosis into various severity groups. Emergency management. As we have discussed before, the emergency management should proceed as per the PALS guidelines. There are some general measures like ABC. Airway has to be maintained. Breathing has to be taken care of by administering oxygen in the non-threatening manner in the appropriate interface. And circulation has to be taken care of by placing the IV cannula, taking the initial samples of blood for various investigations, and attaching the cardiac monitor and looking for the T waves, blood pressure, and heart rate. It is unless It is very important that unless absolutely necessary, avoid placing a central venous catheter because of the high risk of thrombosis because of the presence of a hyperosmolar hyperglycemic state, as I have told before. And if at all it is inserted, it should be removed as soon as the child's clinical status permits and the child does not need the central venous catheter anymore. Thirdly, if the child's central venous catheter is needed to be placed for a longer duration, we should always consider mechanical and pharmacological prophylaxis with low molecular weight heparin, especially for children more than 12 years of age. Now coming to the first step of management of diabetic ketoacidosis. The first step of management is to decide regarding the IV therapy. The specialty of ISPAD guideline is in a special scenario when there is minimal dehydration and the child is tolerating oral fluid and the child is conscious, this guideline gives an option to not give IV therapy, rather use subcutaneous insulin and oral hydration, contrary to BSPD guideline, which tells that all patients of DKA, be it mild, moderate, or severe, require IV hydration. But the specialty of ISPD guideline is in minimal dehydration patients or patients who are tolerating oral fluid. The patient, if the patient has mild DKA, then we can give subcutaneous insulin and oral hydration rather than giving IV hydration and IV insulin. But if the patient has moderate dehydration, or you can think that moderate to severe DKA, and if the patient has shock, in both of these cases, IV fluid followed by IV fluid bolus followed by fluid resuscitation and IV insulin will be required. There is no role of subcutaneous insulin and oral hydration in moderate to severe DKA and DKA patients having shock. So suppose the patient does not have mild decay, suppose the patient has moderate or severe decay, or suppose the patient is not tolerating oral fluid. In all those cases, you will require IV hydration and IV fluid therapy for the patient. For the first step of management is we have to assess the patient for shock. Shock means decreased perfusion at the tissue level. But as we already know, as we have already discussed, that low blood pressure or shock develops in a very less number of patients. Normal blood pressure or even high blood pressure can develop in 28% of patients of diabetic ketoacidosis. That's why we have to take the help of special parameters or special clinical features to diagnose shock in the children. So what are those parameters? If the urine output is low, that is oliguria. If the peripheral pulses are weak and impalpable, like thready pulses, if there is decreased level of consciousness, or if there is hypotension or low BP, in presence of any of these four conditions, we have to assume that the patient has shock. So what do we do if suppose there are no clinical features like this? Then we'll assume that the patient does not have shock. But the patient does not have shock, but as we all know, all the patients of diabetic ketoacidosis have some or other level of fluid deficit in the body. So we have to correct that deficit. So how do we correct that deficit? We correct that deficit by giving 10 to 20 ml per kg of normal saline bolus over 20 to 30 minutes. So basically it's a slow bolus. So how much amount we give? 10 to 20 ml per kg. What fluid we give? Normal saline. Over what period of time we give? 20 to 30 minutes. So this is to be done in a patient who does not have any features of shock at the presentation. But on the contrary, if the patient has one of these features, that means oliguria, weak impalpable peripheral pulses, decreased level of consciousness, or hypotension, then we have to assume that there is presence of shock in the child. Shock means more severe fluid deficit. That means we have to use a higher amount, we have to use a faster rate. That means what is that higher amount? Not 10 to 20 ml per kg anymore, it is 20 ml per kg. Bolus is always normal saline and we have to give it as quickly as possible, not like slowly like 20 to 30 minutes. We have to give it as quickly as possible and we have to repeat these boluses till circulation is restored. Circulation is restored means till all the signs of shock that were present before have disappeared or till the signs of fluid overload have appeared. Those are the endpoints of fluid resuscitation. So what is our first step of management of diabetic ketoacidosis? Our first step of management of diabetic ketoacidosis is assessing if the patient has shock. If the patient has any of these clinical features of shock, then we have to assume that shock is present in the child. We have to give a normal saline bolus of 20 ml per kg as soon as possible. If the patient does not have shock, that means does not have any of the features of shock, then we have to assume that shock is absent. We have to give a normal saline bolus of 10 to 20 ml per kg 20 to 30 minutes. Why 10 to 20 ml per kg? When do we give 10 ml per kg and when do we give 20 ml per kg? That depends upon your clinical judgment. So if you think that the patient has mild decay, pH is like 7.28 or 7.29, it is just satisfying the criteria of diabetic ketoacidosis, so maybe you can use a lower amount. But if suppose the patient's pH is 7.21, it is almost at the borderline of moderate diabetic ketoacidosis, so maybe you can use a 20 ml per kg bolus. So it is completely depending upon your clinical judgment. And while placing the initial IV line, we have to draw all these investigations initially, so that it will help us in the management of the diabetic ketoacidosis and management of diabetes with its precipitating cause. So what are those investigations? We have to draw for blood glucose, we have to draw for serum urea, creatinine and electrolytes, that is sodium, potassium and calcium and phosphorus. We have to draw the CRPQ or quantitative CRP to diagnose any infective etiology that has precipitated this DKA. We have to do the blood gases for diagnosis. We have to do the plasma ketones for diagnosis. HbA1c to monitor the last 3 month control of glycemic level. Thyroid function test and celiac screen maybe to diagnose if it is a secondary diabetes. We have to do the chest x-ray, CSF analysis, throat swab, blood culture and urine analysis as appropriate if we are thinking that the infective trigger of the DKA lies anywhere here. And we have to suspect sepsis if there is presence of fever or hypothermia, hypotension, refractory acidosis or lactic acidosis. In these conditions, we have to suspect sepsis. So while placing the IV line at the beginning, we have to simultaneously draw these investigations from the blood so that we don't have to prick the child again. So we have to keep a clinical assessment and record of consciousness, where we have to monitor the hourly GCS, that is Glasgow Coma Scale. It has to be related to the degree of acidosis and cerebral edema. We have to do the full examination so that we can find the signs of cerebral edema, infection and ileus. What are the signs of cerebral edema? Headache, irritability, slowing the pulse, rising blood pressure, reducing consciousness and papilledema. Those are the late signs. We'll discuss this in detail later. We have to weigh the child because all the fluid calculation, insulin administration, etc., all depends upon the weight of the child, that we are going to discuss very soon in the next slide. So we have to weigh the child and use the current weight of the child for the management rather than the ideal weight. So next, coming to the main part, that is the fluid management. So the total fluid requirement of the patient is depending upon or is decided by the total fluid deficit in the child and total maintenance fluid of the child. I hope you have all understood this, that the total fluid requirement of the child depends upon the total deficit and the total maintenance fluid. So how much is the deficit? The deficit depends upon the initial pH of the patient and it has to be replaced over 24 to 48 hours. We will follow the general principle that we will always correct the deficit over 48 hours, because the slower the fluid we give, there is the less chance of development of cerebral edema. So how much is the initial pH? The initial pH is this initial pH is useful in classifying the patient as mild, moderate and severe decay. So mild decay was from pH 7.2 to 7.29, moderate decay was from 7.3 to 7.1 to 7.19 and severe decay was from 7 less than 7.1. So accordingly, if the patient has mild decay, we have to assume there is 5% fluid deficit. If the patient has moderate decay, we have to assume that there is 7% fluid deficit, and if the patient has severe decay, we have to assume that there is 10% fluid deficit. So what is meant by 5%, 7% and 10%? 1% fluid deficit refers to 10 ml per kg of fluid. That means in mild decay there will be 5%, that means 50 ml per kg of fluid deficit. In moderate decay there will be 7%, means 70 ml per kg of fluid deficit. In severe decay there is 10%, that means 100 ml per kg of fluid deficit. This deficit always has to be corrected over 24 to 48 hours. We will always do it over 48 hours. And the maintenance, everyone knows this famous formula. The maintenance fluid for a particular child is calculated by the famous Holiday-Segar formula. What is the Holiday-Segar formula? For the first 10 kg it is 100 ml per kg, for the next 10 kg it is 50 ml per kg extra over the 1000 ml, and for any additional weight above 20 kg it is 20 ml per kg. Maximum for a 75 kg child, if the child's weight is more than 75 kg, we can assume adult guideline, or we can take up the adult guideline to calculate the maintenance fluid. So this slide is the most important slide of diabetic ketoacidosis management, because the total fluid requirement of a particular patient will be calculated by adding the total deficit and the total maintenance. Deficit will be decided by the initial pH, maintenance will be decided by the Holiday-Segar formula, just like any other child. The important point to remember is that the initial normal saline bolus amount given to patients before starting lift fluid therapy, that we had decided in the previous slide, when the shock was present and shock was absent, what were the amount of normal saline bolus we are giving, the amount has to be subtracted from the calculated deficit amount, because this is the total deficit, that is 5%, 7% or 10%, but some part of this deficit we have already corrected by giving a slow bolus, or giving a 10 to 20 ml per kg or 20 ml per kg bolus already before calculating all this. That means that bolus is also a part of this deficit. That's why while calculating the deficit later, we have to subtract that amount of fluid bolus from this deficit. So we'll calculate by two examples. So coming to the first example, suppose a diabetic ketoacidosis patients come to you whose weight is 20 kg, who is a 6-year-old, and the initial pH is 7.15, and there are no signs of shock. There is no oliguria, no weak impalpable peripheral pulses, the consciousness is normal, blood pressure is normal, so there is no shock. So you have to calculate the fluid requirement for the patients. So how do you calculate? You can pause the video and do in a pen and paper, and then you can match whether your answer is correct or not. So how do you calculate? First, we'll calculate the deficit. So how do we calculate the deficit? The deficit depends upon the initial pH. How much is the initial pH? 7.15. 7.15 means mild decay, moderate decay, or severe decay. It is moderate decay because it is lying between 7.1 to 7.19. So the deficit is depending upon moderate decay. Moderate decay was how much? 7%. 7% means 70 ml per kg, because 1% refers to 10 ml per kg. So how much is the deficit? 7%. That means 70 ml per kg. That is 20 kg. That means 1400 ml. But as the patient had no shock, the patient might have received a 10 to 20 ml per kg bolus also in the beginning over 20 to 30 minutes. So suppose we have given a 10 ml per kg bolus, that means 200 ml bolus before. So this bolus has to be subtracted from the deficit calculation. So I have subtracted 200 ml from 1400 ml, that brings me to 1200 ml. This is the total deficit amount left, that is 1200 ml, but the deficit has to be calculated over 48 hours. That means we have to give this 1200 ml fluid over 48 hours. So how much it is coming? It is coming at 25 ml per hour for 48 hours. So the deficit rate is 25 ml per hour for 48 hours. Similarly, we will calculate the maintenance. Maintenance is easy to calculate because it is Holiday-Segar formula. For a 20 kg child, the maintenance fluid will be 1500 ml, because for the first 10 kg it is 100 ml per kg, that is 1000 ml. For the next 10 kg it is 50 ml per kg, that is 500 ml. So total is 1500 ml. This is for 24 hours. But we have to give this 1500 ml over 24 hours. So 1500 ml divided by 24, how much it is? It is 62 ml per hour. But we have to continue this 62 ml per hour of fluid along with the deficit till the point the deficit is going on. So this same 62 ml per hour will be going on for 48 hours also. So that's why, what is the total requirement of the fluid now? Total requirement of the child, 25 ml per hour plus 62 ml per hour, that is 87 per ml per hour. That is the total fluid requirement of this patient. This is how a fluid requirement is calculated for a diabetic ketoacidosis patients. So I hope you have understood. If you have not understood, there is some confusion, you can go back few minutes and watch this slide again. If you are confident, then let's try this exercise. Let's try another example, and here you can pause the video and you can calculate yourself. So a diabetic ketoacidosis patient who weighs 60 kg, who is 14 years old, the initial pH is 6.9 and there is presence of shock. That means there is either oliguria or weak impalpable peripheral pulses or decreased level of consciousness or hypotension. So there is presence of shock. So let's pause this video and you calculate the total fluid requirement of the patient by calculating the deficit and maintenance, and then match whether your answer is correct or not. So I hope you have calculated. Let's calculate the deficit. So this is Deficit calculation depends upon the initial pH. Initial pH is 6.1, 6.9. That means it is severe decay. Severe decay means 10%. 10% means 100 ml per kg. 100 ml per kg means 60 kg. 100 ml per kg, that means it is 6000 ml. But as the patient had shock, the patient must have received a 20 ml per kg of normal saline bolus. So 20 ml per kg of normal saline bolus means 20 ml into 60 kg, that means 1200 ml bolus subtracted. So we have to subtract this 1200 ml from this 6000 ml, which comes to 4800 ml. This deficit has to be corrected over 48 hours. That means the rate is 100 ml per hour. How much is the maintenance? Maintenance means for first 10 kg it is 1000 ml. For next 10 kg it is 50 ml per kg, that is 500 ml. That means total 1500 ml. For another 20 kg above 20 kg, sorry, for another 40 kg above 20 kg, that is 20 ml per kg. So 40 ml multiplied by 20 kg, that is 18800. So 1500 plus 800 brings to 2300 ml as per the holiday Segar formula over 24 hours. The rate is coming by 2300 divided by 24, so it is 96 ml per hour. This 96 ml per hour fluid also has to go for 48 hours, so the total fluid rate will be 96 plus 100, that is 196 ml per hour is the total requirement of the patient. So I hope you have understood this calculation of the fluid calculation, because this is the most important slide for the management of diabetic ketoacidosis. So what do you do in case of obese children? The obese children management should be similar to other children, like the ideal body weight calculation is not necessary. The current weight should be used for obese children fluid calculation also. But sometimes if the obese child is weighing more than 65-75 kg, sometimes the fluid calculation can exceed those of adult protocols. In those cases we have to follow the adult protocol itself. That means the fluid bolus initially that we are giving at 20 ml per kg, like that for adults it is 1 liter, and the fluid rate we are calculating like 196 ml per hour or 87 ml per hour in the previous two examples. The fluid rate for adults is 500 ml per hour. So we have to use the adult guideline if the fluid calculation for an obese child exceeds that of adult protocol. So what is the type of fluid? We have discussed the rate of fluid and we have discussed the amount of fluid. But what is the type of fluid? Exactly what fluid to be used? In ISPAD guideline, the type of fluid has following options. You can use a 0.9% normal saline, or you can use a half normal saline, that is 0.45% also. Or you can also use a Ringer's lactate, Hartmann solution, plasma light, basically any isoosmolar solution. But we have to keep in mind that we have to always add potassium to our IV fluids. Why we have to add potassium? We have already discussed that insulin has a known effect of shifting the potassium from the extracellular to the intracellular compartment. Actually, this mechanism is also used in the management of hyperkalemia also. So when the insulin will be administered in the management of DKA, the potassium will get shifted from the extracellular to the intracellular compartment, leading to development of hypokalemia. That's why in our IV fluid we always add potassium at 40 millimole per liter. 40 millimole per liter of extra potassium is added. We have to keep in mind that we should not give oral fluid until the patient is receiving IV fluid and there is presence of ketosis or nausea or vomiting. And if the patient develops a gastroparesis due to hypokalemia, we have to place a nasogastric tube, otherwise there will be development of nausea and vomiting, which will further lead to dehydration, which will further aggravate the diabetic ketoacidosis. So some special points about potassium. All fluids except the initial bolus have to contain at least 40 millimole per liter of potassium chloride, that we have already discussed, that at least 40 millimole per liter of potassium should be added. The exception is evidence of renal failure. Why? Because when the kidneys have failed, the kidney might not be able to excrete this extra potassium load that is being given in the IV fluid. That's why the fluid therapy has to be partially modified or have to be kept in mind depending upon the initial potassium level. Suppose at the presentation you check the initial potassium level of the patient. The result can be one of these three things. Either the patient can be hyperkalemic, that is the potassium level can be more than 5.5 millimole per liter, or the patient can be hypokalemic, that means the potassium level can be less than 3.5 millimole per liter, or the potassium can be normal, that is 3.5 to 5.5 millimole per liter. So we'll discuss each scenario. Suppose the potassium is normal, that means there is no confusion, potassium is normal itself. So what should we do? We should start our normal treatment with added potassium at a rate of or at a concentration of 40 millimole per liter added to the parenteral fluid. But suppose there is hyperkalemia. So what is our risk here? There is presence of hyperkalemia. Suppose the potassium is 6. So if we add potassium now and there is impaired renal function, maybe the patient will not be able to excrete that potassium load that we are giving in the IV fluid, and potassium will start building up in the body. And we all know that when potassium starts build up in the body, there is development of gradually arrhythmia, which is potentially fatal. So basically, if the potassium level initially is more than 5.5, before administering potassium chloride in the IV fluid, we need to have an evidence that the kidneys are working. Because if the kidneys are not working, it is dangerous to give potassium. So by any way, we need to get some evidence that the kidneys are working. So what is the evidence that a kidney is working? If the patient has recently passed urine, or the child passes urine in front of you, so that indicates, or that is an indirect evidence that the kidneys are working. So we can add the potassium. Or second evidence, if the potassium gradually falls to less than 5.5, that means the patient is not hyperkalemic anymore, then also you can add injection potassium chloride to the IV fluid. So I hope you have understood this concept. Thirdly, suppose the potassium is less than 3.5. So what is the risk here? Patient is already hypokalemic. Now with the administration of insulin, patient can become further hypokalemic. So hypokalemia can further aggravate also. So we have to give the insulin for diabetic ketoacidosis anyway, because that is the drug of choice. So we cannot hold the insulin. So what do we have to do? We have to correct the potassium first and then give the insulin, because there is no other way. So how do we do that? We basically correct the potassium level by giving high dose injection potassium chloride via the central line at a maximum rate of 0.5 millimole per kg per hour, and when the potassium level becomes at least 3 or 3.5, then we start the insulin. And we have to remember that as the concentration of potassium is very high here, 0.5 millimole per kg per hour, it is preferably given through a central line rather than a peripheral line, because this high concentration of potassium can cause chemical thrombophlebitis and can damage the vein. So let's revise our clinical features of potassium buildup and potassium depletion in the body, because sometimes the emergency determination or emergency report of knowing the serum potassium may not be available. So we may need to take the help of ECG also to diagnose hyperkalemia and hypokalemia. So this is the normal ECG wave. This is the P wave, this is the QRS, and this is the T wave. When there is gradual buildup of potassium in the body, first the T wave starts getting peaked. The peaked T waves develop, or we call it a tall tinted T wave. Then when further potassium gets accumulated in the body, the P wave becomes flattened and the PR interval becomes prolonged. When potassium starts building up more and more, the QRS complex starts becoming wide, and when before death, that means the potassium becomes very high, like 9 or 10, potentially fatal conditions, there is development of sinus wave or sine wave. That means you cannot differentiate which is P, which is QRS, which is T. You cannot differentiate. Basically there will be sine wave. So these are the ECG manifestations of hyperkalemia. Similarly, when hypokalemia develops, like potassium gets depleted from the body, so there will be development of tall P waves. That means the amplitude of P wave will increase. The amplitude of P wave will increase, followed by the T wave starts getting flattened or inverted. When the T waves get inverted, later on there is development of U wave also, and lastly the QRS complex becomes wide also. So tall or peak in amplitude of P wave, widening of QRS complex, inversion of T wave, development of U wave. These are the manifestations of potassium depletion or hypokalemia in the body. So how do we start the drug of choice, that is IV insulin? So IV insulin, as I have already discussed before, we have to start it 1 hour after starting the IV fluid therapy. How to calculate IV fluid we have discussed in detail with 2 examples also. So basically we have started the IV fluid therapy, we have to give the 1 hour gap. In that 1 hour we should not give any insulin, the IV fluid has to go on, and after 1 hour of IV fluid has gone, then only we have to start the IV insulin. The only preparation that should be used is regular insulin, and the rate is 0.05 to 0.1 unit per kg per hour. the rate is 0.05 to 0.1 unit per kg per hour. But there are some special situations in which the severe DKA is present or the adolescent patient has DKA. We have to start at a higher dose, 0.1 per kg per hour, because the patient has a higher risk of developing morbidity and mortality. If the initial pH is less than, if the initial pH is more than 7.15, that means mild to moderate decay, you can start at a lower dose, that is 0.05 unit per kg per hour. Special situation is if a particular patient has age less than 5 years and the patient has mild decay, that means the pH is 7.2 to 7.29, you can start with a further lower dose of insulin also, that is 0.03 unit per kg per hour also. Lastly, use your clinical judgment when to use 0.05, when to use 0.1, use your clinical judgment. With experience that will come. And for those patients who have continuous subcutaneous insulin infusion pump, we have to stop the pump before starting IV insulin, because suppose a continuous subcutaneous insulin infusion pump is implanted in the body and you are giving regular insulin from outside, that regular insulin from outside will act as an extra dose in addition to the continuous subcutaneous insulin infusion pump. So you have to shut off the pump first or stop the pump first, then give the external insulin so that you can titrate appropriately. So how to prepare the insulin infusion for easy administration? 1 ml of insulin contains 40 unit of insulin. 1 ml contains 40 unit. So for convenience, we have to prepare the insulin in such a manner so that it will be very easy for us to administer. So what do? We take 1 ml of insulin and add it to 39 ml of normal saline. We take 1 ml of insulin and add it to 39 ml of normal saline. So now in this total solution, what is the total volume? 1 ml plus 39 ml is 40 ml. What is the total amount of insulin? 40 unit, that is 1 ml. So now our final solution is 40 ml volume with 40 unit insulin. So what is the final concentration? 1 unit per ml. So basically we have equalized the ml to unit. So when we have to, or we want to give 0.1 unit per kg per hour of insulin, what we have to basically do is we have to give 0.1 ml per kg per hour, because now unit and ml has been equalized in this solution. We have to, when we want to give 0.07 unit per kg per hour, we will give 0.07 ml per kg per hour. Similarly, when we want to give 0.05 unit per kg per hour, we will give 0.05 ml per kg per hour, because the unit and ml have now been equalized. And always the insulin solution has to be given through a syringe pump like this, whatever syringe pump is available in your facility. So let's do an example. Suppose there is a 20 kg child and you want to give the 20 kg child, due to some indication like severe decay or something, you want to give him at 0.1 unit per kg per hour, and you have prepared the solution as per our discussion in the previous slide. So 1 unit is equal to 1 ml. So how much basically you will give? Unit has become equal to ml, so 0.1 unit per kg per hour is now basically 0.1 ml per kg per hour. So what is the 0.1 ml per kg per hour multiplied by 20? 2 ml per hour. So basically, if for a patient of 20 kg, if you give 2 ml per hour, that becomes 0.1 unit per kg per hour. Similarly, for a child who is 30 kg whom you want to give at 0.05 unit per kg per hour, basically you have to give at a rate of 0.05 ml per kg per hour, that is 1.5 ml per hour. So I hope you have understood this. So how to titrate insulin therapy? With the administration of insulin therapy, as the insulin is the drug of choice for the child, the blood ketone levels should start falling, the acidosis should start improving, and the hyperglycemia also should start improving. So the expected rate of fall in beta hydroxybutyrate or blood beta hydroxybutyrate is 0.5 ml per liter per hour, 0.5 millimole per liter per hour. If the fall in beta hydroxybutyrate level is less than that, then we have to increase the insulin level, because this is the expected rate of fall. And what is the end point? When do we stop the insulin therapy? Actually, we have to stop the insulin therapy when acidosis, ketosis, everything has been corrected. That means pH is not less than 7.3 anymore, it is more than 7.3. Bicarbonates has become more than 18 millimole per liter. The blood beta hydroxybutyrate has become more than 1 ml millimole per liter, and there is closure of the anion gap, because diabetic ketoacidosis is a known cause of high anion gap metabolic acidosis. So we have to remember that persistent ketonuria occurs for several hours after blood levels have returned to normal. That means blood ketonemia corrects first, followed by urine ketonuria, which can take some hours, days, or even weeks. So we don't have to rely on, or we should not rely on, normalization of urine levels or urine ketone levels for titrating the insulin. Rather, we should always rely on the normalization of blood ketone levels for titrating the insulin. Suppose if IV insulin is not available, this is the specialty of ISPAD guidelines. Suppose IV insulin is not available in your facility, but subcutaneous insulin is available. So what you can do? In place of IV insulin, you can try subcutaneous insulin every 4 hours. So what is the dose? Just like in IV insulin, the dose was 0.05 unit per kg per hour to 0.1 unit per kg per hour. Here the dose is 0.13 to 0.17 unit per kg per dose every 4 hours, that is 0.8 to 1 unit per kg per day in divided doses, and the doses have to be increased or decreased by 10 to 20% based on the blood glucose level, which we have to do every 2 to 3 to 4 hourly. So we cannot do hourly glucose just like in a good setup with IV insulin, but if you are doing subcutaneous insulin, it will take some time to get absorbed, so there is no point in doing the hourly glucose. Rather, we have to do the blood glucose every 2 to 3 or 4 hourly intervals. Role of bicarbonate therapy, I have already told that the administration of sodium bicarbonate is contraindicated in diabetic ketoacidosis because it increases the morbidity and mortality by multifold, and it is not associated with, or it is not having any therapeutic benefits. Only we have to give sodium bicarbonate in very severe life-threatening conditions when the metabolic acidosis itself is so severe that the metabolic acidosis itself can cause death. What are those situations? Two situations are there. When the severe acidosis is there, like for example pH of 6.8 or 6.7, the acidosis is so much severe that it impairs the myocardial contractility. That means whatever drug, whatever inotropes, whatever thing you will give to the patient will not get the adequate amount, and because the myocardium has failed, the myocardium contractility has impaired because of the severity of acidosis itself. That's why in that situation you have to give sodium bicarbonate to correct the acidosis up to some extent, so that the impaired myocardial contractility can be corrected up to some extent. Second situation is when there is life threatening hyperkalemia. Suppose the potassium is 9, 10 or 11 or something like that. The hyperkalemia can cause death by precipitating an arrhythmic event. So in that case, you have to think about managing the hyperkalemia also. What are the treatments available for hyperkalemia? We know that calcium gluconate, insulin plus dextrose, sodium bicarbonate, and sometimes beta agonist nebulization also we can use for management of hyperkalemia. So it is one of those indications. Only two indications we will give sodium bicarbonate. One is life threatening hyperkalemia, another thing is severe metabolic acidosis or severe acidosis impairing the myocardial contractility. As the diabetic ketoacidosis patients have a hyperosmolar state in their body, there is very high risk of venous thrombosis in the patient. So always central lines should be avoided as much as possible. If at all the femoral lines or any central line is placed, it should be kept for minimum time as much as possible and should be removed at the earliest when the patient does not need. Suppose if the patient is more than 60 years, 16 years, or the patient is a young woman who is taking oral contraceptive pills, or if the patient is very sick with femoral lines, that like the patient is not mobile, so all those conditions increase the chance of development of venous thrombosis. In all those cases, we have to consider instituting thromboembolic prophylaxis in form of low molecular weight heparin. So obviously the treatment, titration and all those things in diabetic ketoacidosis depend upon absolute monitoring of the patient. So monitoring by nursing officers and monitoring by medical officers is very important. We have to maintain an hourly fluid balance chart. We have to maintain an hourly capillary blood glucose chart. The capillary blood ketones have to be measured every 1 to 2 hours. Vital parameters we have to measure as frequently as possible, at least every hourly. We have to monitor the consciousness by the Glasgow coma scale every hourly or half hourly if the patient is very sick or the patient's initial condition was very sick, and we have to monitor the patient's body weight twice daily because we are instituting a very high amount of fluid to the patient. Additionally, the doctor should make the extra effort to monitor the patient repeatedly by monitoring the glucose, the blood gases, the blood ketones, the clinical status and the vitals, the ECG tracings and the cumulative fluid balance. So the monitoring is absolutely necessary for appropriate management of diabetic ketoacidosis. More frequent assessment is needed if the patient is very sick, like or patient has high risk, like if the patient's age is less than 2 years, or if the pH of the patient was less than 7.1, or any other reason for special concern. Suppose for example there is a patient of paralytic ileus or gastroparesis or acute pancreatitis. If there is any special concern, we have to monitor the patient more frequently. Now coming to the concept of pseudo-hyponatremia in the patient. So the concept of pseudo-hyponatremia I have already discussed in the BSPD guideline. If you have understood that, you may not watch this and skip this, but if you have not understood, it makes no harm to understand it again. Why or what is the pseudo-hyponatremia? So normally what happens in the body, this is the cell and this is the outside the cell. So this is the intracellular compartment, this is the extracellular compartment. In the intracellular compartment there is some sodium, and in the extracellular compartment also there is some sodium. This is the total sodium content of the body. Now when the hyperglycemia develops, as in a case of diabetic ketoacidosis, the total sodium content in each of these compartments remains the same, it is clear. But as the hyperglycemia has developed in the extracellular compartments, because the serum compartment, the osmolarity of this compartment increases, because glucose increases the osmolarity. So as the osmolarity of this compartment increases, water molecules always have a tendency to move from the compartment with lower osmolarity to the compartment with higher osmolarity. So what the water molecules will do? The water molecules from inside the cell will move to a compartment with higher osmolarity, that is outside the cell. So now the total content of sodium in this compartment is the same, but now as the amount of water in this compartment has increased, there will be dilutional hyponatremia. So this sodium content will be same, but when we measure the sodium, the value will be lower than actual, or the value will be lower than expected, because the measured sodium will come less than the actual value, because of the accumulation of more water molecules by shifting from the intracellular to the extracellular compartment. So this is not actual hyponatremia, because the sodium content is the same, but this is the pseudo hyponatremia. Why? Because this is false hyponatremia. The measured sodium is coming less because of the accumulation of water molecules, because of the development of hyperglycemia. So the measured sodium coming less than the actual value due to the shift of water molecules from the intracellular to the extracellular compartment, due to the development of hyperosmolar condition as a result of the hyperglycemia, is called pseudohyponatremia. So why it is important to know about the pseudohyponatremia? Suppose the patient's blood glucose is 100 and the patient's sodium is somewhere here. As the blood glucose starts increasing by 100 milligram per deciliter, the measured sodium that we get in the reports is less. The actual sodium is this, but the measured sodium that we get in the reports is this. Similarly, when the blood glucose further increases, the measured sodium further falls. The blood glucose further increases, the measured sodium further falls, and when the blood glucose further increases, the measured sodium further falls. So for every 100 milligram per deciliter increase in blood glucose above 100, the measured sodium falls by 1.6. That is the concept of pseudohyponatremia. So let's discuss an example. Suppose the initial sodium of the patient was, or initial glucose of the patient was 100 milligram per deciliter, and the initial sodium of the patient was 145 millimole per liter. Now the glucose of the patient is 500 milligram per deciliter. So how much has the glucose increased? By 400. 400. For every 100, sodium measured value will fall by 1.6. So for 400, so how much it will fall? 1.6 into 4, or 1.6 multiplied by 4. So what will be? 6.4. So when the blood glucose comes 500, the measured sodium that we get in the report is 138.6. That is 145 minus 6.4, but the actual sodium is 145, but the measured sodium is 138.6. Why it is important to know that? Because as the glucose starts decreasing with treatment, ideally the measured sodium should start increasing, because that phenomenon gets nullified. So as the glucose starts falling in the management of diabetic ketoacidosis, the sodium more and more represents the actual value, or the sodium gradually decreases, sorry, increases. If the sodium does not increase, stays the same, or further decreases with improvement in hyperglycemia or with reduction in hyperglycemia in the management of DKA, we should assume that there is excess fluid accumulation in the body, which can be an early marker of cerebral edema in the child. So that's why it is important to know the concepts of pseudohyponatremia, because with normalization of glucose in the management of diabetic ketoacidosis, the sodium value should gradually increase. If it doesn't increase or rather falls, then it can be an early sign of cerebral edema and we have to take the appropriate steps. So this is the formula of corrected sodium that has been described or that has been derived from the same concept that we described earlier. So what is the anion gap? The diabetic ketoacidosis is a known condition with high anion gap metabolic acidosis. So the anion gap formula is given here. What is the normal value? It is 10 to 14 millimole per liter, but in diabetic ketoacidosis it is slightly high, that is 20 to 30 millimole per liter. But suppose the anion gap in a diabetic ketoacidosis patient comes very high, like more than 35 millimole per liter, then we have to think that not just this acidosis, there might be additional lactic acidosis also due to sepsis or poor perfusion in the child, and we have to take the appropriate steps to manage that. So it is important to know about the concept of hyperchloremic metabolic acidosis also, because we are administering a large amount of fluid containing chloride. We are administering normal saline, that is sodium chloride. So we are administering a large amount of fluid containing sodium chloride, basically chloride. So preferential renal excretion of ketones instead of chloride is happening in diabetic ketoacidosis. That can lead to accumulation of chloride in the body, that will develop hyperchloremic metabolic acidosis. When the patient of diabetic ketoacidosis with the management, after the management has started, starts improving clinically and in every other way, but there is no improvement of acidosis, we have to keep a high index of suspicion for the possibility of hyperchloremic metabolic acidosis also. Hypophosphatemia, it is seen in 50 to 60% of cases. Why does the hypophosphatemia occur? During diabetic ketoacidosis, phosphate is lost during decay due to osmotic diuresis, and there is also shift of phosphate from intracellular to extracellular compartment due to metabolic acidosis also. So that will lead to hypophosphatemia. And during treatment also, when we are administering a lot of amount of fluid that does not have any phosphate, the phosphate in the body that is already there gets diluted, and hypophosphatemia can happen, and insulin mediated entry of phosphate into the cells, just like potassium, can lead to hypophosphatemia. So if severe hypophosphatemia, that is less than 1 milligram per deciliter, happens, it will be associated with a lot of clinical conditions like metabolic encephalopathy and seizures, reduced myocardial contractility, ventricular arrhythmias, respiratory failure, proximal myopathy, hemolytic anemia, dysphagia, ileus, rhabdomyolysis, etc. So in these conditions, we have to treat the hypophosphatemia by administering potassium phosphate. But we have to keep in mind that any phosphate that we are administering can bind with calcium in the body and can precipitate hypocalcemia at any point of time. So suppose you have continued treatment and with starting of appropriate treatment in diabetic ketoacidosis, the improvement should start within 4 to 6 hours at least, ideally. But suppose there is no improvement after 4 to 6 hours of treatment also, then what should you think of? Then you should think of the possibility of a sepsis, in which institution of an appropriate antibiotic therapy will be required for the permanent treatment. You have to consider the possibility of insulin dosing errors, fluid calculation errors, the possibility of a blocked or leaking lines or excessive urine loss also. And you have to recheck your calculations, re-ensure that whatever you have advised, those has been administered or not, whether the line is kinked or any line is blocked, or there is thrombophlebitis or extravasation or whatever. So you have to think about all those causes. And if the ketone levels are not falling within 6 to 8 hours, consider increasing the insulin dose to more than equal to zero point 0.1 unit per kg per hour, because we have already discussed that with appropriate treatment, the insulin, the ketone body or blood beta hydroxybutyrate level should fall at a rate of at least 0.5. So you have continued the treatment, and with fluid and insulin and all those, glucose starts falling, should start to fall. but the main purpose of administering the insulin is to reverse the ketosis and to reverse the acidosis. So till the point of time the acidosis and ketosis have not been corrected completely, you have to continue the insulin infusion and you cannot stop the insulin infusion. But as the glucose level starts to fall with continuing same level of insulin infusion, there is chance of precipitation of hypoglycemia. That's why when the blood glucose level falls to less than 250 to 300 milligram per deciliter, you have to change the normal saline to DNS. That means you have to add 5%, 10% or 12% dextrose depending upon the blood glucose level, so as to prevent the precipitation of hypoglycemia with continued administration of insulin with the treatment of DKA, diabetic ketoacidosis. And we have to consider reducing the dose of insulin from 0.1 to 0.05 or continue at 0.05 if started at that level also. As per the local protocol, when if the insulin infusion is to be continued at a higher rate 0.1, then you have to add 10% dextrose rather than 5% dextrose. Special considerations: do not stop the insulin infusion while glucose is being infused, and insulin is required to switch off the ketone production. The main purpose of insulin administration is to reverse the ketosis and the acidosis. When the blood glucose level falls to less than 150, you can consider adding 10% or 12.5% dextrose. But when the blood glucose falls to less than 70, that is when hypoglycemia develops, that is the cutoff for diagnosing hypoglycemia, less than 70, you have to hold the insulin infusion for 1 hour or stop the insulin infusion for 1 hour, and you have to manage the hypoglycemia in line of giving a 2 ml per kg of 10% dextrose bolus, followed by adding the or increasing the dextrose concentration of the IV fluid. That should be the management of hypoglycemia. And as we have already discussed, if acidosis is not correcting, after appropriate therapy, you have to consider the possibility of insufficient insulin, inadequate resuscitation, fluid calculation errors, sepsis, hyperchloremic acidosis, and salicylate or other prescription or recreational drug overdose. Insulin management after resolution. Suppose now the resolution has happened, that means pH is more than 7.3, bicarbonate is more than 18 millimole per liter, there is no ketone bodies anymore in the blood, or it has fallen to less than 1, and the complete resolution of diabetic ketoacidosis is there. So you have to start considering starting of subcutaneous insulin and stopping the IV insulin, but you cannot do that at a time. What you have to do, you have to keep an overlap period of 15 to 30 minutes at least between IV insulin and subcutaneous insulin. So suppose at 10 a.m. the all the endpoints have been achieved and the decay has been corrected, you continue the IV insulin for 30 minutes more, that means 10 a.m. to 10:30 a.m. also, and at 10 a.m. you give the first dose of subcutaneous insulin. This 15 to 30 minute crossover period should be there so as to ensure that patient does not go into decay again. And after this 30-minute overlap period, if the patient's everything, vitals and clinical parameters and lab parameters, everything is normal, you can consider switching off the IV insulin and continuing with the subcutaneous insulin at an appropriate dose. How to start the subcutaneous doses, I'll make a separate video for that. That is an entirely different class. So one special mention about clinically significant cerebral injury. The term cerebral edema has not been mentioned specifically in the ISPAD guidelines, rather it refers to clinically significant cerebral injury. Why the clinically significant cerebral injury occurs? Because we are administering rapidly a lot of amount of fluid which results in changes in serum osmolality. This was the previously thought of mechanism, but now three new mechanisms have come up. We are seeing that there is cerebral hypoperfusion, a development of a hyperinflammatory state due to increase in cytokines and chemokines, and there is disruption of blood brain barrier leading to development of a clinically significant cerebral injury in a patient who is suffering from diabetic ketoacidosis and when the treatment is started. So the degree of cerebral edema or clinically significant cerebral injury is directly proportional to the degree of dehydration and the degree of hyperventilation. That means if two patients are there, suppose one patient is having moderate decay and another patient is having severe decay, obviously the severe decay has 10% deficit and the moderate decay patient has 7% deficit. So it has been seen that the more severe the degree of dehydration, there is higher chance that the degree of cerebral edema will be more severe. And similarly, suppose two patients are there, same age, same weight, same severity of decay, but one person's one patient's respiratory rate is 60, another patient's respiratory rate is 40. The patient having respiratory rate of 60 will be having higher risk of development of cerebral edema because it is directly related to the degree of hyperventilation. Also, the higher the PCO2, there is increased risk. The higher the blood urea nitrogen, there is increased risk, and the more severe the acidosis, there will be increased risk of clinically significant cerebral injury. And the mortality is quite high, that is 21 to 24%. That means out of every 100 patients, 4 to 5 patients, out of every 100 patients, one fourth to one fifth, that means 20 to 25 patients will die due to cerebral injury. So, what is the cerebral edema? Abnormal shifts of water across various compartments of the brain parenchyma lead to cerebral edema. It is mainly of two types, that is cytotoxic cerebral edema and vasogenic cerebral edema. What is cytotoxic cerebral edema? In cytotoxic cerebral edema, mainly the cells are unable to maintain the ATP dependent sodium potassium ATPase membrane pump. This leads to accumulation of water inside the cell, and there is cellular swelling and reduction in the extracellular volume because the water is preserved inside the cell rather than the outside the cell. So what happens here is that the gray matter white matter differentiation is lost. Like you can see in this side, there is clear cut distinction between gray matter and white matter, but on this side the gray matter white matter distinction is lost. This is due to cytotoxic cerebral edema. It mainly happens in cases like cerebral ischemia, or it can happen in DKA also. What is the another type of cerebral edema? It is vasogenic cerebral edema, in which the blood brain barrier is disrupted and it mainly affects the white matter via leakage of fluid from the capillaries, in which in contrast to the cytotoxic cerebral edema, the gray matter white matter differentiation is maintained, and in fact it mainly involves the white matter and extends like finger like projections. Can you see in this case? The white matter extends in a finger like projection and the gray white matter differentiation is maintained. As blood brain barrier disruption was one of the mechanisms of cerebral edema in decay, the cerebral in decay, both cytotoxic and vasogenic cerebral edema can be possible, or clinically significant cerebral injury can be possible. So how do we diagnose clinically significant cerebral injury? On In contrary to BSPD guidelines, the ISPAD guidelines provide clear-cut criteria for diagnosing clinically significant cerebral injury. These are the diagnostic criteria, these are the major criteria, and these are the minor criteria. What are the diagnostic criteria? Any abnormal motor or verbal response to pain, any decorticate or decerebrate posturing, any cranial nerve palsy, mainly 3, 4, and 6, and any abnormal neurogenic respiratory pattern like grunting, tachypnea, chain-stokes respiration, and apneusis. These are considered the diagnostic criteria. What are the major criteria? Mainly three. Altered mentation on confusion and fluctuating consciousness, that is mainly related to CNS. Sustained heart rate deceleration, that is more than 20 beats per minute, not attributable to improved intravascular volume and sleep state. That means in a patient of shock, when you administer intravascular fluids, the heart rate is expected to decrease. If we have ruled that out, and if we have ruled out the sleep state, if the heart rate has decelerated by more than 20 beats per minute and it is sustained, you have to consider that a major criteria. Third is age inappropriate incontinence. What are the minor criteria? Vomiting, headache, lethargy, not easily arousable, diastolic blood pressure of more than 90 millimeter of mercury, and age less than 5 years of age. These are the diagnostic, major, and minor criteria. Presence of one diagnostic criteria plus two major criteria, or presence of one major criteria plus two minor criteria, have a sensitivity of 92% to diagnose clinically significant cerebral injury and a false positivity rate of only 4%. That means these diagnostic criteria, major criteria and minor criteria, can be used to diagnose clinically significant cerebral injury with high accuracy. So what if we have diagnosed clinical significant cerebral injury, but after that what? When we have diagnosed, we have to treat with either hypertonic saline, that is 3% saline, or 20% mannitol. Those are the treatment options for clinically significant cerebral injury or cerebral edema. What is the dose of hypertonic saline? It is 2.5 to 5 ml per kg over 10 to 15 minutes, or decrease, or 20% mannitol doses 0.5 to 1 gram per kg over 10 to 15 minutes. And we have to consider reducing the IV fluid dose. We can directly make it half the maintenance rate, or we can gradually decrease it, like For example, from 100 to 90 ml per hour, then to 80 ml per hour, then to 70 ml per hour. Like that also we can decrease, because the more rapid the fluid administration, the higher the chance of cerebral edema. Here we have to remember that 2.5 ml per kg of 3% hypertonic saline is equiosmolar or equimolar to 0.5 gram per kg of 20% mannitol. So both are equivalent. We have to remember that we have to consider that the mannitol effect takes place after 15 minutes to 120 minutes, that means 2 hours after the administration of the first dose. But if suppose even after administration of first dose 15 to 30 minutes have passed and there is no clinically significant improvement in the cerebral edema signs, we have to either consider a second dose of mannitol, or we have to consider adding hypertonic saline to the treatment. What are the other complications? Other complications that can be possible in the management of DKA are hypoglycemia, hypokalemia. Both are due to insulin. Systemic infections can be evidenced by fever, raised lactate, raised inflammatory markers. Aspiration pneumonia can happen. We have to put an nasogastric tube for a vomiting child or a child with impaired consciousness. Abdominal pain in diabetic ketoacidosis may be due to liver swelling, gastritis, bladder distension, ileus, and appendicitis. And there is a list of complications that can happen at any point of time in the management of diabetic ketoacidosis, like permanent severe neurological sequelae, renal tubular damage and acute kidney injury, hypokalemia, hypocalcemia and hypoglycemia, severe hypophosphatemia, hypochloremic alkalosis and hyperchloremic acidosis, renal failure, acute pancreatitis, deep vein thrombosis, pulmonary embolism, rhinocerebral mucormycosis, aspiration pneumonia, pulmonary edema, ARDS, prolonged QT intervals, air leak syndromes like pneumomediastinum and subcutaneous emphysemas, rhabdomyolysis, and ischemic bowel necrosis. So I hope you have understood the ISPAD guidelines in detail. If you have doubt at any point of time, you can tell in the comment section, or you can go back to that section of the video. Now we'll practice two case scenarios so that we have understood our guidelines or not. So this is the first case scenario. This is an 11-year-old male who weighs 30 kg, who has presented to you with pain, abdomen, vomiting and fast breathing for 1 day, and there are no signs of shock. The RBS or random blood sugar is 561 milligram per deciliter. The venous blood pH is 7.15, bicarbonate is 5.6, PCO2 of 14, and the plasma ketone level is triple plus. The serum potassium is 3.9, serum sodium is 139. So with this, I hope there is no confusion in diagnosis, that the patient is a case of diabetic ketoacidosis. So what is our first line of management? This is not a mild DKA, so we have to obviously institute the IV therapy, both IV fluids and IV insulin. First, what we have to do? First is the consideration of requirement of IV bolus. Bolus has to be given to the every patient, but how much bolus to give, over what period of time to give, depends on the signs of shock. As it is already mentioned here that there is no signs of shock, what was our first recommendation? No shock, so we'll give a 10 to 20 ml per kg of bolus over 20 to 30 minutes. So suppose if we give a 10 ml per kg of bolus, that is 300 ml over 30 minutes, this bolus has to be subtracted from the deficit calculation later. Now let's pause the video and calculate the total fluid requirement of the patient. So I hope you have calculated now. So how much is the deficit? Deficit depends upon the initial pH. Initial pH is 7.15. That indicates moderate decay. Moderate decay means 7% deficit. 1% is 10 ml per kg. So 70%, 7% is 70 ml per kg. 70 ml per kg refers to 2100 ml in this case. 2100 ml, the bolus has to be subtracted. That means 2100 minus 300, that is 1800 ml. This deficit correction has to be given over 48 hours. So 1800 divided by 48 hours comes 37.5 ml per hour. This is the deficit correction. But we have to calculate the maintenance fluid also. So how much is the maintenance? For a 30 kg child, holiday Seeger formula, for first 20 kg is 1500 ml. Then for every additional kg it is 20 ml per kg. That means 10 kg. So 200 ml, 1500 plus 200, that is 1700 ml. 1700 ml per 24 hours, that means 71 ml per hour. So how much is the total fluid rate? 71 ml plus 37.5, that is 108.5 ml per hour. So that is our total fluid requirement of this patient. So whenever a case of diabetic ketoacidosis comes, You have to immediately maintain a chart like this so that you can do hourly monitoring of the patient and advise the fluid accordingly. So suppose the patient has come at 6 p.m. and blood glucose is 561, pH is 7.15, bicarbonate is 5.6, PaCO2 is 14, serum sodium is 139, potassium is 3.9, GCS is 11, and other symptoms are nil. And based upon our calculation in the previous slide, you have calculated that you have to start at the NS plus KCl at 108.5 ml per hour, and as expected before, in the first hour you will not give any insulin, and then the second hour you will start the insulin at 0.05 ml, 0.05 unit per kg per hour, or 0.05 ml per kg per hour, because we have prepared the solution like that. So suppose at 8 p.m. RBS is decreasing, pH is increasing, bicarbonate is improving, PaCO2 is improving, sodium is increasing as expected. We have understood the concept of pseudo hyponatremia. Potassium is normal, GCS is same. So do we need to make any changes? No. Our fluid will be remain same, NS plus KCl at 40 millimole per liter. Fluid rate will remain same, insulin rate will remain same, everything will remain same. So see the next hour, everything is increasing, improving, pH is increasing, bicarbonate is increasing, PaCO2 increasing, potassium is normal, sodium is increasing, GCS is also improving. So basically the patient is improving, we don't have to do anything else. So now see, the RBS is decreasing, acidosis has slightly worsened, and so has the bicarbonate. PaCO2 has slightly decreased, which is bad. Sodium should increase, but sodium has fallen. But hyperglycemia has also worsened, so it is actually expected. Nothing to be done here. The treatment has to be remain same, but as the sodium has fallen, we have to keep a high index of suspicion for possibility of development of cerebral edema or a clinically significant cerebral injury. See, at the next hour, the RBS has reduced, the acidosis has improved, or everything is improving, but still the sodium is slightly in the lower range or not increased. So still we have to consider the possibility of cerebral edema. If any signs and symptoms of cerebral edema appear here, we have to take the appropriate steps. So see here, the glucose has fallen, everything is improving, GCS is also improving. Do you need to do anything else? See, the RBS has fallen to less than 300. As per the ISPAD guidelines, when the RBS falls below less than 300, as the insulin will be going on, because still there is acidosis, so we have to add 5% dextrose to the IV fluid. So what we will do, we'll add 5% dextrose to the IV fluid, rest everything will remain the same. Similarly, when the fluid RBS is further falling, patient is overall increasing, improving, everything is constant, so we'll make the same treatment continue. But what here, the RBS has further fallen to 125. That means when the RBS falls below 150, rather than 5%, we have to make the fluid 10% dextrose. So we have to add 10% dextrose, rest everything should remain same. See, with the improvement of hyperglycemia, the sodium is increasing, which is expected due to the concept of pseudo hyponatremia. Now see, now suddenly the RBS has fallen below 70. That means the patient has developed hypoglycemia. So at this point, what will you do? As the patient has developed hypoglycemia, we will hold off the insulin for 1 hour. So we'll hold up the insulin for 1 hour, we'll continue the IV fluid, but to manage this hypoglycemia, we have to give a bolus of 2 ml per kg of D10. The patient was 30 kg, so 60 ml of D10 bolus needs to be given for the management of hypoglycemia that has developed at this stage. Again, at the next hour, the RBS is 136, so below 150 means we have to give 10% dextrose to the IV fluid, and rest all everything has to be continued. And see, the RBS has increased to 173, so we have to change this 10% to 5%, rest everything has to be continued. But still see here, the 7.31, 7.32, that means the patient is not in DKA anymore, the acidosis has corrected. So as the acidosis has corrected, we have to start considering reducing the IV fluid and reducing the insulin, but insulin is already started at the lowest possible dose, so we have to start reducing the IV fluid. And as soon as the patient becomes completely okay, like GCS 14 is almost okay, if the patient can tolerate oral fluid, we have to consider switching to subcutaneous insulin while gradually reducing the IV fluid, and appropriately as per the RBS values we have to add the 5% or 10% dextrose to the IV fluid. So if you maintain a chart like this, then your management of diabetic ketoacidosis will be perfect. So coming to the second case scenario, so this is a 4-year-old male weighing 22 kg. The patient presented with a complaint of pain, abdomen, vomiting and fast breathing for 1 day, poor peripheral pulses. The patient is obtunded and there is increased capillary refill time. The random blood sugar is 523. The venous blood pH is 6.98. Bicarbonate is low. PCO2 is low. Plasma ketone is triple plus. Potassium is 5.6 and sodium is 124. So obviously there is no confusion that this is a case of diabetic ketoacidosis. Now let's pause the video and calculate your fluid requirements. So I hope you have calculated the fluid requirements. So what will be our first step? Our first step will be to see whether the patient is in shock or not. So poor peripheral pulses are there, patient is obtunded, there is increased capillary refill time. All these things are pointing towards the presence of shock. So shock is present, that means we have to give a 20 ml per kg of normal saline bolus as quickly as possible. Patient is 22 kg, so we have to give a 20 ml per kg bolus, that is 440 ml as quickly as possible. And assume that shock has been corrected after one bolus, so we don't have to give any boluses anymore, and this 440 ml has to be subtracted later. So how much is the deficit? Deficit depends upon the initial pH. Initial pH is 6.98, that means severe decay. Severe decay means 10% deficit. 10% deficit means 100 ml per kg. 100 ml per kg is 2200 ml, but you have to subtract the bolus from that, so that comes to be 1760 ml. This deficit has to be corrected over 48 hours, so 37 ml per hour. And what is the normal maintenance? Maintenance will be calculated as per the Holiday-Segar formula. It is coming to be 1540 ml over 24 hours, so 64 ml per hour. So what is the total fluid requirement? 64 plus 37, that is 101 ml per hour. So similarly to last case, we have to maintain this chart. So at the presentation time, this was the vitals and this was the parameters, everything. So we have started NS plus 40 millimole per liter of potassium with a fluid rate of 101, and as there was severe decay, we have started the insulin at 0.1 ml, 0.1 unit per kg per hour, or 0.1 ml per kg per hour. Now see, with the reduction in hyperglycemia, everything is improving, but the sodium has fallen from 124 to 118. So we have to consider that with resolution of hyperglycemia, sodium should rise, but it is falling. So what does that indicate? That indicates that there might be possibility of cerebral edema. So what we have done here, we have slightly reduced the fluid rate from 101, we have made it 90. Now see the next hour, RBS is decreasing, acidosis is improving, sodium has started increasing, which is expected. So we'll make our fluid rate again 101 ml per hour and we'll continue the same fluids. Now at the next hour, hyperglycemia has improved, acidosis is improving, everything is improving, even the GCS is also improving. So we have to continue the same fluid. Now the RBS has fallen to less than 300. So we have to add 5% dextrose to the IV fluid. Rest everything has to be remain same because the parameters are within the expectation. Now it is 224, acidosis is improving, patient's GCS is improving, PCO2 is improving, sodium is improving, so same treatment has to continue. When the RBS falls below 126, as everything else is improving, we have to add 10% dextrose rather than 5% dextrose to the fluid. When the RBS falls to 76, it is not hypoglycemic range, so everything has to remain the same. When the RBS is 110, we have to still continue the 10% dextrose. And as the acidosis has now improved, we have to start considering the reduction of the insulin rate, that is 0.09 unit per kg per hour. And as the acidosis goes on improving, we have to reduce the insulin rate gradually from 0.09 to 0.08 to 0.07 to 0.06, and lastly 0.05 unit per kg per hour. But with treatment, you see, as the insulin goes on, potassium is falling. So as the potassium starts falling, we have to add the potchlor syrup or IV potassium chloride. If the patient is able to take, as is indicated by improving GCS, we can give oral potassium, or if the patient is not able to take, or if there is severe hypokalemia, we have to give IV potassium chloride via the central line at a rate not more than 0.4 millimole per kg per hour. So I hope you have understood. So I hope you have understood the detailed management of diabetic ketoacidosis as per the ISPAD guidelines. So if you like this video, you can press like, hit share and subscribe with your friends, with your juniors, with your seniors and fellow pediatricians and clinicians who are interested to manage the diabetic ketoacidosis properly. And very soon I will be posting a short video in which I compare and point out the major differences between the BSPD and the ISPD guidelines of management of DKA. Thank you.